my colleagues, and my dear friends. It's really a big honor that you have bestowed upon me, and in Dr. Professor Gopinatha Menon sir, who is kindly remembered as a legendary teacher, I'm deeply honored to be the recipient of this. I'd like to start by saying if I've seen further, then it's by standing on the shoulders of giants in this gathering also. And right from Babu Rajendran sir, the list is long and legendary, and to find a place in the 25th in that particular list is itself so happy. I'm so happy about it. Just a word about my father and mother. They were doctors, and so I was privileged as a young person seeing doctors live. And my father was a very busy practitioner, Dr. K.S. Pillai from Thrissur. He was an orthopedician, and I was probably meeting him only after 10 p.m. 10 to 12 p.m. we would go out for shuttle badminton, etc. But one important thing that he distilled upon me is the work culture. And second thing is what he asked me once. There are two types of doctors. One type of doctor who has love and respect of the public, and the other kind of doctor who has the love, respect of the peers. And most of us, if you ask any young doctor, they would want both. But it's extremely difficult to get both. As a doctor, if my father stepped out into town, there would be hordes of patients surrounding, asking him where he is, and he was a public figure there. If I go out into Ernakulam, nobody recognizes me. I am as anonymous as anybody. But yes, the second possibility was that, you are recognized and respected by your peers is what I worked with. And my mother's quiet affection and a lot of time actually gave all this. In my MBBS, I was fortunate to have, in my entire learning career, I was fortunate to have great teachers. And Mary Kuriakos Madam, who is actually a completely different person from all the other people in medical college service. She used to be so futuristic. She used to be doing retinal surgeries at that point of time, buckling, scleral buckling, etc. Struggled to do, but she used to do. And Alex sir and Charles sir and Radha Madam all shaped my interest towards ophthalmology, even though my first passion was orthopedics. But finally, I landed up in All India Institute under these three great people. Professor Tiwari was a giver. He would give more than take. He would give knowledge, he would give surgery, he would give everything, anything what is his, it's yours. That was his he did not covet for anything. He was a giver, and as a student, I have been blessed by his affection. And on the left is Dr. Dinesh Talwar, one of the finest theoreticians that I have seen. He looks into a particular problem with a methodical rhythm that is too good. And on the right, you see Dr. Lalit Verma, the most practical person, the man manager who gets the job done. However he wants to get it done, he will get it done. So these three people were my mentors at that point of time and shaped the way I looked at things even now. And yes, in Cochin, we had a lot of seniors who knew my father and thus knew me and was working together with me. The people standing on the back, Mahesh and Thomas, we were three together, almost started together, almost growing together in terms of surgery. We shared our worries and surgeries, failures and successes, and moved on. And Giridhar sir was a great inspiration in terms of a person whom you want to follow. So that brings me to the 25th Professor Gopinatha Menon Memorial Oration, Beyond the Fundus, Artificial Intelligence, New Molecular Targets, and Innovative Drug Delivery Methodologies. How it can help reshape our retina practice. So this thing that the retina is a window into the whole human body, was drilled into me quite early by Professor Tiwari. And this is the only place where you can actually see the blood vessels, the nerve, and the internal milieu in which it is bathed in. And so the same vessels, which can have problems elsewhere in the body, can actually be picked from the retina. And it is already part of a routine eye exam. So why not use it for diagnosing beyond the retina was the question. So I'm presenting my AI work here. It's a big team, it's not me alone. It's a huge team which I'll share with you. Retinal screening from research to the clinic. We are looking at 3 conditions initially, and then 2 deployment paths and from 1 retinal photograph. So what does AI add into the ophthalmic? So what an ophthalmologist sees, or what we look at fundus photographs, how can an AI be different? It definitely sees beyond the human eye. When Google brought in its first AI, they could differentiate between man and woman. I cannot. I'm sure nobody can. Nobody of the clinical doctors can differentiate between man and woman, or a cigar smoker or a non-cigar smoker, or an alcohol person or non-alcohol person. So these are what AI can do if you give them and train them with enough data. So it sees far beyond what we can see. And one particular foundation architecture of AI that you do, many diseases you can pick up. And it can, as you can see in the presentation, we are trying to make it smaller and smaller to fit your pocket. So 1 photographs, and if we can pick up 3 of the world's leading killers, the kidney disease, heart disease, and stroke, then that would be a master stroke, is what I thought. So initial, maybe 2012, 2013, we were looking at segmentations, automatic segmentations, defining the retinal image, features, etc. Like, for example, simple segmentations like this, hard exudate segmentations. And once you segment, see, we all know hard exudates, but we don't quantify hard exudates. We don't quantify the transition of hard exudates through the retina. And that is what this can does. This can bring in a mathematical modeling to the hard exudates, depending on the intensity of the hard exudate, the size of the hard exudate, the depth of the hard exudates, the proximity to the center of the fovea. All these can be looked up and made into a marking system, a scoring system. So microaneurysms, there's a microaneurysmal turnover which we do not usually look at, and rapidity of turnover versus slow turnover will actually look at what happens 10 years down the line or 15 years down the line, or even predicts other diseases. So for doing such kind of work, you need to automatically segment and look at it. And that is what we were doing, soft exudates, hard exudates, all these things we were able to do. Finally, we looked at retinal vasculature analysis. So these are 9 particular quantific features in the artery, in the vein, and in the artery-venous ratio, which brings out about 27 quantific features from the vessels, which we can study mathematically in each of these diseases. And that differentiates between many of these vascular diseases, not just retinal diseases, but about the systemic diseases like the coronary artery disease, stroke, or renal failure, and a lot of other diseases to come as well. So you can actually model predict on this is the vessel segmentation, and based on the segmentation you run an algorithm and differentiate between the stroke patients versus normal patients. This is a CAD stroke versus normal. Each of these vascular features, you can see the differentiation, and you can see how they can be different. So the surface area, the mean absolute deviation, branching points, bifurcation points, terminal points, tortuosity, fractal dimension, vessel density, vessel length, each of these things will be different in different diseases. And that is one thing which I thought would be important till I understood more about AI. This is what I can understand, you can understand, we clinicians can understand, because these are visible to us. And these visible things, how we differentiate between one particular disease versus the other particular disease, is what we usually look at. But the AI machinery works completely differently, and I'll come in a minute, but that they can pick up much more than these. So the first of the thing which I'm going to go into is chronic kidney disease detection. We had about 1,500 patients and about 10,000 images. Now it is about 20,000 images. This is an ongoing work. Now we have about 20,000 images of chronic kidney disease patients. And our area under the curve to detect a patient with chronic renal failure was about 82%, which tells us that if about 82% sensitivity in picking up a disease just by one fundus photograph. So this fundus photography, again, as we know, we all take great pride in very good quality photographs with a 1 crore machine. But that cannot be used for screening. And so whatever we used for all these AI-based work was handheld non-mydriatic cameras with low quality, Indian non-mydriatic cameras with low quality, with 40 degrees, which can be easily taken, which can be easily procured at about 2.53 lakhs rupees, and which can be easily taken to any place to do this type of screening. And so, why we should screen this? I mean, this is an understatement. About 800 million people with CKD and diagnosis needs a blood test. So whenever you have a screening protocol, you require a blood, which means you require a nurse, which requires a consent, which requires a lab. And so population screening, like we do for ophthalmology, is extremely difficult. So retinal vasculature, which is already linked to CKD, and we know that it reveals it, so we can train with AI and look at it. So this particular design was about 10,000 patients from 10,000 images from over 5,500 patients. We had already retina trained AI model called RetFound, which is already trained in 1.3 million retinal images. So that is the architectural model that we took for this particular study, and then we fine-tuned it with our own patients' images with the 40 degree of view, 512 by 512 images. We did a 5-fold cross evaluation. We did not do all the images testing in a row. We divided it into 5 different groups and tested it separately. And a different camera from the same hospital, a Clarius, was used for a validation. We developed the model using a handheld camera and validated it using a very high quality image from a high quality camera. So with 277 patients. And we also looked at 2 public data sets with unrelated cameras. So this was the pipeline, the image collection, the pre-processing, which has the cropping, the color normalization, a lot of other things. Foundational model, I said RetFound was the model which was used. We fine-tuned it with our own patients' data and images. Internal validation, as I said, 5-fold cross-validation, and external validation using a second camera, as well as 2 public data sets. That's 83%. So retina-specific foundation model, as I said, this higher resolution camera. So when we used the same algorithm into Claris images, which is much more better, higher quality, we had much more better results. So this is a 5-fold, you can see the 5 different folds there, about 0.86 to 0.79. These are the different areas under the curves there. The sensitivity was about 80%, specificity reaching a little above 70, but that was okay when you are looking at for screening, not for diagnosing or confirming the diagnosis. So if you have a large population to screen, and if you want to just pick up people, 80% sensitivity and 70% specificity is reasonably okay. There's going to be some false positives, which we are all right with once they come to a clinician. It's about bringing from 100 crowd, bringing about 20 people out of that crowd, and that is why that is. So now when retina-specific pre-training was done, like for example, over our backbone, when we used the RetFound, there was a significant increase of about 0.10 again. And when we used Claris images, the AUC increased to 0.93. 93% was the area under the curve, which means that when we train the algorithm on a lower quality camera, and use that algorithm with a higher quality camera, our results significantly skyrocketed. Huge improvement. This improvement is not so easy. Like till 80 is rather all right. From that 81, 82, 83, each percentage is very, very difficult to reach. And so then we looked at why did the machine pick up renal diseases? And this is called explainable AI. So this is the image where the machine is looking at this particular part, the red part, and that is the area which the machine is concentrated to say that this is a renal failure. So we we had evaluated which are these areas. And those areas are well within that vasculature network. And so initially we were thinking that the vascular differentiation based on the 27 quantific variables that we see and we have established would make a difference. But no, machine makes its own differences if you train them. Only that the data which goes into the machine has to be fairly good. That is the only thing. Now, so we have a real signal, good, consistent 82.5, 83 AUC for 5 validations. Retina trained AI outperformed all the general models and successfully transferred to another camera. So this is efficient and a step forward for assembling screening. So the next area that we looked at was stroke. So we have about 1,730 patients, about 12,000 images. Now we have currently about 20,000 images. We had about 82% area under the curve. So again, stroke is again a leading cause of death and disability, costly and invasive screening. The Framingham stroke score or some of the other things, the stroke prediction risk would require an MRI, a carotid Doppler, probably embolic screen, which is all more difficult for screening. And a single click of a camera, if you can give it, it is really amazing. And so we looked at vasculature, which finally, retina is an extension of the brain itself. It's a low-cost alternative. It is acceptable, affordable, and available to a lot of people. And foundational model, which we have already created, we have used for stroke patients as well. So these are the about 12,000 images and 888 normal patients. Stroke patients were 842. And this is the pipeline: image collection, feature extraction, patient aggregation, pre-processing, attention fusion, and validation. So there were again almost 82.5 to 80% in the 5-fold validation studies that we did. So sensitivity was about 73 and specificity was about 75 here for determining stroke. These are the pooled results, and so the takeaways are meaningful discrimination is possible at about 80%, which means if I say that the machine puts the risk of somebody developing a stroke to be about 80%, it's 80% chance that this patient will develop a stroke at some point of time, or already have developed some subclinical brain infarction, etc. It is lightweight, so 27.7 million is a big number, but it is enough to run in a modest hardware like our ordinary computer. And positive predictive value of 74 and negative predictive value of 75 was balanced across the outcomes. And we have made this algorithm as well. Next is coronary artery disease. That's the biggest killer. We have about 3,400 patients and 22,000 images. Now we've reached about 30,000 images of coronary artery disease patients. We know that CAD is the most common cause of death, and about 30% deaths are caused by coronary artery disease. Angiography, CT, even in a population setting, it is extremely difficult to run a treadmill test for a lot of people. It's time consuming, it requires hardware as well as people to run it. So one click of the camera, and if you're able to pick it, that is really great. And this is the metrics, and this is the same pipeline that we use: image collection, pre-processing, foundation model, which we use RedFound again, fine-tuning, validation, and explainability check. So when you say this, I would just want to go into that classification pipeline. These are all engineered things which we are not very much knowledgeable about, but slowly I'm gaining more knowledge into it. So we have looked at different architectural models, right from a baseline CNN model to V2. So our V2 model was the best with MIL. There's another addition which we did. So these are all different models on which we train and test and train and test, and we look at which is the best algorithm possible in our Indian images of patients. So V2 with vessels was the best, and that is the development journey. So RedFound, dual stream cross attention. Dual stream means that, in one patient itself you can have FFA, OCT, as well as fundus images. So that's a different image things coming in together. Regularization, label smoothing, the vessel is another pipeline. So I added the vascular features to this and looked at whether that will improve the sensitivity, and yes, it was improving the sensitivity. So MIL is again another thing which I will come to, multiple instance learning. So like for example, one patient has 2 to 8 images, but a single, see that is a single patient, but he has 2 to 8 images. So some of the images may not have a problem, some images may have a problem, and that creates a little bit of a confusion in the machine's mind. And to alleviate that particular confusion, we looked at this particular thing called multiple instance learning. So all the images of one particular patient were fed together, and the machine was made to learn that, and that also improved our sensitivity. So finally, what we have currently is a prediction output like this. So CAD risk 0.84. This is what will come, and the machine will also show which are the areas which they are looking at in order to pick up the disease, which is like the red and the yellows here. So that's the explainable AI. So we would say somebody has a risk of 80% for CAD versus 20% risk for CAD. Ultimately, my idea would be that if you can screen them like that, and all the people at risk for CAD or stroke, you can secondary prevent them by giving one antihypertensive, one anti-cholesterol, and probably an ecosprin. That would at least delay his heart attack or stroke by 10 more years, and that's the idea. So we have about 80%, that's the discrimination. So explainable AI, as I said, was what we looked to validate what we have learned. So the takeaways here is there is a strong discrimination about 80%, high precision with positive prediction value of about 85%. It looks at the vascular structures, not artifacts for looking at it. And it is the largest and the most realistic test cohort for this comparison in the world. Because currently, if you look at systemic diseases, the UK Biobank has about 1.67 lakh images. And they have the systemic data of all these 85,000 people. And we are a close second currently with more than about 1 lakh images, and it is ongoing. So we are sure that in a recent future, we will be the world's #1 in terms of the systemic diseases, retinal images data. So we have 3 tests, okay, 3 algorithms. Now we have to devise into a single common protocol so that with one click of the camera, you can look at these 3 diseases simultaneously. And that required some more engineering and technological help from their side. They handheld us, and finally we were able to do that. So this is what Dr. Mahesh was basically telling us, Retinos AI, grading diabetic retinopathy as well as all the non-ophthalmic diseases from retina, which in diabetic patients, which means CAD, stroke, renal disease, these 3 we have already done. Neuropathy and diabetic foot also be added to them, and we are looking at this particular thing, in which it's a 5-stage severity grading is also bringing in. So whether the disease is going to be more severe or less severe is what we are looking at. This is currently in development only. Now another area is biomarker reporting. Now we all have now looked at retinal biomarkers, imaging biomarkers, OCT biomarkers. How can an AI report, like if you give an image, the AI will say that these biomarkers are positive for this, and these biomarkers can be prognostic biomarkers, therapeutic biomarkers. So these are things that we are bringing in, so that is also underway. The report writer is only started. I mean, it's not really great. It'll come in. It'll require a little more refinement. Now this is another work that we had done together with another faculty, estimating macular thickness from a fundus photo. Currently, diabetic macular edema requires monthly OCT examinations, and that requires that the patient come to the doctor, and the places where there is no OCT, you require the test, and if there is no edema, no injection, the patient goes back. How is it if we are able to take that fundus image, and from the fundus image we can get the thickness? Currently we are able to get a plus minus 20 microns difference, which means that we are close enough, but it is not absolutely accurate. But we would be able to probably predict based on a retinal fundus image, a handheld retinal fundus image, which patient requires an injection, which patient does not require an injection. And that's a big thing forward for a patient who is living in the rural area, who has to come about 3 to 4 hours to visit a doctor, do an OCT, and tell him that everything is okay today. this is an Ophtho AI, local so LLM, the large language models have broken into Chat GPT, it's mobile, but the problem is always about, they will hallucinate and they will talk about things that are not correct. So Ophtho AI, we have used purely the scientific data only, not the any sites in the Google or anything like that to bring in, and we have about 97% automated test cases passed, and that is in development again here. Yes, it had bugs, it was fixed, one was still open, one issue is still open, so we are refining that particular thing. Now OCT disease detection is another area. So till now I was talking about fundus images, which would be helping in mass screening of people, not only for ophthalmology, but for other diseases as well. Now coming to OCT-based auto detection as well as auto detection of the biomarkers, etc. So AMD and DME, we know the biomarkers. Primary biomarkers would be the fluid, the intraretinal fluid, the subretinal fluid, the sub-RPE fluid, which can be quantified by this AI reporting. And we have successfully looked at different biomarkers, and now the next thing we were looking at was how to move the whole thing into a mobile. The problem was that our algorithm was about 1.3 GB, and to run that algorithm you required a fairly strong computer to do that, which is not possible you are trying to somehow reduce the dependency on heavy duty equipment, and if you require a very high-end computer to run it, then it becomes a little redundant. So how can we transfer that 1.3 GB algorithm into a smaller GB which can fit a mobile phone was the next thing, and how can we obviate the need of an internet so that offline we can do that. So we looked at it disease by disease. Bringing CKD detection to our pocket was the first thing. So we made that into a 4.4 MB app, mobile app. From 1.3 GB, we reduced it into 4.4 MB, and we looked at the training. So it's like a master and a student. So it is like the master is 1.3 GB. The images and the training and all those Ratnachurukam of that was transferred into the student, which is about 4.4 MB, and we had AUC of about 0.81. That is fairly good, 80% accurate as the the big algorithm version. So why digital research model? I have already told, it's too large, and so we cannot deploy it in the market. No internet, and in rural areas, that internet may be patchy, it may be a little difficult, and so we looked at, I learned from the teacher approach, and built to run on an ordinary phone, and not on a high-end iPhone, and run fully offline once installed. So again, we looked at 70-30, 70 was the training and 30 was the testing, and again fivefold we looked at one leakage bug was caught and fixed, and fold by fold we checked against the teacher, and this is the teacher student, 0.85 for the teacher, 0.81 for the student. This 3.4 million parameters reduced to 6.9 million parameters, 1.2 GB reduced to about 4.4 MB, and that is why you can now just screen, put it onto your mobile offline, and you can look at risk of kidney risk, heart risk, and stroke risk. That's the problem that's probably going to come. So capture and instant on the device itself you can analyze, works without internet, and risk score. So one model we have done, now we have to add the other two models and integrate them into the single mobile. So the takeaway here is that 44 times smaller, accuracy is about 0.85 to 0.81, 0.04% accuracy reduction, but okay, verified end-to-end and built for real clinics. So here, there is one conversation here, and three conditions which I said, renal disease, cardiac disease, and stroke. And now, this is conversational software for these three diseases which I put up, and this is like artificial intelligence. Basically, we are looking at here the analysis of what the machine looked at, and this is called the RetMob LM. So usually we have the large language models. Here we have also incorporated a visual language model, VLM, into this picture, and also added the LLM for disease discussions as well. So you put in the image inside, and you have a possibility of adding some of the systemic conditions here, whether there is CKD, stroke, and what is the serum creatinine, what is the GFR, etc. And you put in, and the machine will tell you the changes also. Like for example, over a period of time, if his blood pressure is getting controlled and controlled and controlled, or his diabetes is getting better, his cholesterols are getting better, the risks also changes. And that real-time risk changes can be looked up, and you can also chat with that particular person. As I said, it is not based on Google, this thing is based on scientific Scopus or PubMed indexing. So here the vision is screening anywhere, no internet required, and you have this, you have the report, and the report can be real-time, longitudinally fixed, so that this patient's report can be looked up from 1 year to the next 10 years. So this is the report. So you can see that the patient is me, 25-year-old male, eGFR. This is the G1, and this is the area. This is the OD and the OS. You can see that the 2 screenings were there. The risk percentage actually reduced over a period of time because things actually got better. And we can also track each of the lab values. So these are algorithms to do that. So usually what we have is 3 screenings, means coronary artery screening, stroke screening, and CKD screening will require 3 visits to 3 doctors. We are looking at a single photo for 3 answers. And this algorithm can actually talk back to you, because visual language, large language, and audio language have been put in. So it is a consultation, it's a full consultation. It is not just a report. It talks to you as to what did the machine see to make sure that this is this or this is that. So this is built by trust, and it doesn't hallucinate. That is the most important thing. This doesn't hallucinate, it doesn't edit the chart, it knows when to be cautious. So each of these sentences have been put there because we've tested for them, and improves locally over time. So finally, we have the 3 validated AI models, which are ready to deploy. We require external validation, multi-centric validation, and then the government's approval to make it as a device. Then we have the RET-LM, the clinic companion. Actually, we have a conversational assistant, which is built on image trained on Indian data set, as well as the international data, which is there on the scientific websites, and the mobile app screening on the go. Again, a pocket-sized app with 4.4 MB app, which can work completely offline. So the takeaways are 3 conditions. It explains itself, it's trustworthy, works offline, and that is the destination here. And that brings us to the next big area. I would take about 15 minutes more. So it's the basic biology studies. So this much area was on the artificial intelligence imagology. Now moving into basic biology, started in 2015 with a proteomic study, which I looked at why do some patients respond to anti-VEGF, when do some patients do not respond to anti-VEGF. And I found out that some patients actually have very, very high anti-VEGF levels, which behaves a little differently from the other patients. So the ones with 2,500, 3,000, you can see that the VEGF behavior, even in times of injection, the visual acuity and the central macular thickness are completely different. And that is one particular group. Now, there is a grouping of responders and non-responders. And I try to differentiate between responders and non-responders. Responders were patients whose macular thickness is normalized or reduced more than 40%, or if only 4 injections were required in 6 months. If all these were met, then they were called non-responders. And if all those were not met, then they were called responders. So there was a huge clinical difference between these 2 groups in terms of visual acuity as well as central macular thickness. Looking at the VEGF, actually the non-responders had more injections, and so the VEGF levels were very low, making me understand that it is not VEGF which is driving them, it is something else, and that something else was found out here through cytokine analysis. And these are different cytokines which we looked at in differentiating the non-responder to anti-VEGF versus the responder. And IL-6, IL-8, IP-10, and MCP-1 were found to be very highly positive in the non-responders. Now, if you have a kit which can pick up these 4 cytokines, we can say this guy is a non-responder to anti-VEGF, you can move to steroid or something like that. Now, this is a little far-fetched. Now, can we correlate the OCT biomarkers to these inflammatory biomarkers? That is one surrogate biomarker to correlate with another surrogate biomarker. This is what we have, all of us have, the OCT data. All of us do not have the cytokine levels. So can we differentiate these responders and non-responders based on these differentiation? So we could, in the sense, Spongy had 4 times IL-6 levels, ISOS junction disrupted had very high IL-6 levels, Drill had very high, about 10 times the IL-6 levels. So like that, we were able to make out from the OCT some of the cytokine signatures which can enable us to take informed decisions on management. And that was a very big thing. These are very small numbers because a lot of money needs to be required for running these tests. And finally, we had published these. Now, another important area which I looked at was, can we differentiate which patient will go into a TRD, which patient will go into a bleeding when you have a PDR? So if we know vitreous hemorrhage is, finally we can do a vitrectomy and patient gets very good visual acuity. Whereas a TRD is not like that. It is a very difficult to operate and final results are also not very good. So if you're able to differentiate between the progression of the patient into vitreous hemorrhage or TRD, it will be much better if you can treat them quite early. So we looked at differentiation of those proteins, and so we found out that with vitreous hemorrhage we had about 100 proteins which were about 1,000 times higher concentration than the TRD, and we also found about 100 proteins in TRD which is about 1,000 times higher concentration than the vitreous hemorrhage. Now the next step is to find them out if it is possible to detect them in blood, so that I'm able to pick up whether this guy will go into a vitreous hemorrhage or a TRD down the line. So that's an important predictive biomarker that we have looked at. Next thing is, can we add steroids and anti-VEGF? Some of the studies have shown that if you add steroids plus anti-VEGF, there's about 14-letter improvement in diabetic macular edema, which is higher than probably the monthly injections of anti-VEGF in a lot of people. So we looked at a nano formulation which can combine these two, and looked at a rat's eye to give it. And these are ex vivo studies on sheep eyes or goat eyes. And we are able to show that in ex vivo there is a permeation across the sclera, which means if you can apply topically onto the sclera or to the conjunctiva, it can go transsclerally into the retina. This is done this is the fluorescent staining of the dye inside the vitreous, which tells me that transscleral topical drug delivery of anti-VEGF plus steroid is possible. That's the first step which was done. And then we looked at a reticert which can be put on the fornix, and we looked at its pharmacodynamic studies and how they will act. And we had also done some chorioallantoic tests to look at side effects and the study, etc. So that area is like topical anti-VEGF plus steroid is moving ahead. So we have now reached an area where we have devised the drug. We have a device also which aerosolizes this drug around the eye, which can improve the transscleral delivery of this drug. So it is not far, from injections every month or injections once, or about once in a month, to a device-based drug delivery through topical. So that's the next thing which is coming. So this is the next thing which we looked at. So which is the first molecule which is produced before VEGF? So we all know that VEGF is a target. We all give anti-VEGF injections. But what if before the VEGF there are certain pathways which we can control? Would it not be better? So we looked at Muller cell culture and astrocyte culture, and overlaid proliferative diabetic retinopathy vitreous on that and incubated, and looked at which is the first protein which is coming out. And the first protein which is coming out was something called GM-beta, and that's a precursor of all the bad pathways, so the GM-beta. And we looked at GM-beta in disease versus non-disease, and we found out that it is higher. And we also looked at GM-beta expression in the brain, in the spinal cord, in the retina, etc. And we also had one more important thing. We found out an anti-GMF beta which can be given orally. So this can actually reduce the GMF beta phosphorylation, and it can reduce the VEGF levels as well. So this is an oral drug. It works in two ways. One way is to actually reduce the VEGF once it goes into the retina, which is actually less concentration than if you give an injection. And the second way is gut microbiome access. Orally it is taken, and we also looked at the gut microbiome, which shifted from an inflammatory gut microbiome in rats, these are all in rats, to a non-inflammatory gut microbiome. And actually this is reducing the VEGF levels higher with oral than with injections. So that's again a very, very interesting thing which has come out. So based on these, we started two PhDs. One is oral drug delivery of GMF beta inhibitor. You can see that these are streptozotocin based rats, and this is the normal retina of those, and this is the diabetic retinopathy. You sacrifice the animal and get the retina and understand that this is diabetic retinopathy. And we are looking at GMF beta treated rats. You can see the disease activity when it is high. This is the phosphorylated GMP, which is getting significantly reduced in the treated patients. And in these patients, we are now looking at the VEGF levels also to see whether they are reducing. And this is the quantification of the VEGF, the GMF beta levels in the retina 1 hour later, and the retina and the vitreous 1 hour and 30 minutes later, which is significantly coming in. So oral treatment is reducing the phosphorylation of the GMF beta, which in turn reduces the VEGF levels. So that is in the animal stage. The next thing is about the topical drug delivery of the same thing with a nano drug delivery methodology, which can take it inside the eye. This would be minus the gut microbiome axis. So we found out that it is moving inside the eye, and here you can see that there is the peak levels are found out in about 0.2, which is the minimum inhibitory concentration that is required. And right from the cornea to the lens to the vitreous to the retina, this is there. And you can see that when the higher concentration is there, the concentration inside it is reducing. We are in a phase where we are in vitro and in vivo in rats regulating the quantity or the concentration of the drug for the best results. That is the area which we are in currently. And these are the rat retinas that we are taking, and this is healthy control rats. And now with the disease, you can see a lot of changes which are happening here. You can see the neovascular changes. This is after streptozotocin induced diabetic retinopathy rats. And this is about 6th week after the induction into diabetes. And then these are all again diseased rats with multiple, there's a hard X-ray here, there's a neovascularization here, like that. And this is after treatment. You can see that some of these patients, some of these rats are improving slightly. Like for example, this neovascularization here has completely regressed here by the 2nd week, and by the 6th week it is all regressed. So we are able to get results in rats based on these particular diseases. We also included AI-based rat retina comparisons between treated and non-treated. It is just a start. It is not a because we already have the vascular segmentation loop in hand, so we are using these to just segment these rats' retinas and trying to find out. You can see that these are almost normal, and you can see a lot of vessels have dropped out here, and after treatment you can see some of them are slightly improving. So these are my AI projects. I would just say that these are my basic biology funded projects, clinical trials, and the Indian Clinical Trial Network, which Mahesh told. And these are the PhD programs. I would just like to say that these are the patents that we have looked at. And the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. And this is my family, whom I probably sacrifice, because all of us, know that we are all manual laborers doing clinical work from morning till evening, and later after that or in between that only we get time to do all this. And all this takes, believe me, takes a lot of time. And this is my team. Dr. Menon has come here, who is spearheading my research. And this is Dr. Menon. And this is my big team now in 2026, about 35 people. Started in 2019 with this group. And we are growing. We have trying to break the barriers of science and making India proud again. I would just like to say that there is no greater advocate of research than our Chancellor, Mata Amritanandamayi Devi. She pushes into research so much that each time she spends a lot of time in that, and she says, if I make one more hospital, you will touch a few lakhs people, but if you do cutting edge research, it can help billions of people. And that is the push that we have right from the top, and all the deans and directors and all those people are running around doing more and more research, and she's making them run for that. Thank you very much for your kind attention.